Greetings. Today we'll take a close look at the Integrated Motivational Volitional Model, or I'll just call it IMV for short. And it's a contemporary testable theory that explains how suicidal thoughts form and why some people move from thought to action. The IMV was developed to integrate what we know from clinical, social, and cognitive research into a sequence: a background context, a motivational phase where ideation or a suicidal ideation develops, and a volitional phase where ideation converts into behavior. In short, it's an ideation to action framework that highlights when and why to intervene. The pre-motivational phase, the model begins, is the biopsychosocial background that sets the scene for ideation. This includes stress diathesis model, traits like genetic, personality, long-term vulnerabilities, for example, childhood trauma, and current life stressors, for example, financial problems, relationship conflicts. These background factors don't directly cause an attempt, but it increases the probability that later stresses will trigger the motivational processes. Think of the phase as the soil in which suicidal thinking can take root. Now, the motivational phase is the heart of the IMV, and the two proximal cognitive affective states are central: defeat or humiliation. It's a subjective feeling of failed struggle, loss, or powerlessness. Second one, entrapment, the sense that there is no way out, that one is trapped by circumstances or internal state. The model proposes that defeat leads to entrapment in the presence of certain appraisal processes. Crucially, several motivational moderators influence whether defeat becomes entrapment and then suicidal ideation. These include rumination, repetitive negative thinking that keeps the mind stuck, problem-solving deficits, perceived burdensomeness, and low belonging, and hopelessness about change. When defeat is combined with entrapment and motivational moderators fail to buffer this, suicidal intent or ideation is likely to emerge. This sequence of defeat to entrapment to ideation is a key testable claim of IMV. The volitional phase explains why some people with strong suicidal ideation go on to attempt and others do not. This phase is defined by volitional moderators, factors that increase the likelihood that ideation is enacted. Important volitional moderators include access to means, for example, guns, news, medications, high places, impulsivity, and poor behavioral control, exposure or habituation to pain and self-harm, which can increase acquired capability, planning and intent, and fearlessness about death or pain tolerance, or a mental rehearsal of what happens after death. The IMV emphasizes that these are mechanisms of enactment. They don't create ideation per se, but they determine whether ideation is translated into behavior and action. This separation helps target prevention in a way that it can reduce ideation via motivational interventions and reduce attempts by restricting volitional enablers. So there have been empirical tests done upon the IMV constructs, and what it tries to operationalize is the defeat and entrapment via validated scales, rumination and problem solving with cognitive measures, social connectedness with belongingness scales, and volitional moderators via measures of impulsivity, means access, and a history of self-injury. Many studies focus on particular links, so for example, defeat, entrapment to ideation, rather than testing the entire model in one sample. So what the current evidence and empirical work shows that it gives qualified support for the IMV model. Multiple studies show defeat and entrapment are strongly associated with suicidal ideation. The defeat entrapment to ideation pathway has been replicated in other samples. Motivational moderators, so rumination, low belonging, perceived burdensomeness, hopelessness, and further affect whether entrapment produces ideation. Volitional moderators reliably differentiate between those who attempt from ideators in many studies, so access to lethal means, impulsivity, and habituation are commonly replicated. Recent systematic reviews conclude that IMV is a promising empirically grounded framework, but also note that studies vary in how comprehensively they treat the full model and that effect sizes vary by sample and method. Limitation and nuances needs to be also considered. Many studies are cross-sectional, so causality and temporal sequencing are still under question and examination. Not all studies test the full IMV chain in a single longitudinal design, so partial tests are the more common approach. Measurement, there is usually a measurement heterogeneity, different entrapment, defeat, and impulsivity skills, and sample differences. So students, let's say, for example, or patients. So with that produces variability in effect sizes. And there's now also momentary dynamics, so how defeat and entrapment fluctuate day to day, and that's more increasingly studied with ecological momentary assessment, but the evidence base is still growing. So the clinical implications of IMV has direct clinical implications because it separates what to treat from how to prevent action. Motivational interventions target defeat and reduce entrapment and improve problem solving, reducing rumination and increasing social connectedness. These reduce ideation risk. So volitional interventions, on the other hand, target means restriction, reduction of impulsivity, manage exposures to self-harm cues, and attempt to reduce habituation to pain. And with the reduction of these, there is a lesser chance of that ideation becoming an attempt or death. In practice, this means combining therapies that relieve psychological pain or psychache by Rich Schneiderman, and with practical safety planning and means restriction. So to strengthen IMV's utility, the field needs more prospective longitudinal tests of the entire model, better harmonization of measures, and studies that test interaction among moderators. So for example, whether rumination amplifies defeat and leads to entrapment only when belonging is low. Also, diverse cross-cultural validation is needed to see how pre-motivational backgrounds alter pathways. So recent reviews emphasizes these priorities. Now with that, here are the key takeaways. First, IMV is a tripartite ideation to action model that centers on defeat and entrapment as the motivational core, and volitional moderators as enactment mechanisms. Second, empirical support is growing, particularly for defeat and entrapment, and the role of volitional enablers, but tests are often partial and methods vary. Third, clinically, the IMV suggests dual strategies to reduce entrapment and ideation, and separately reduce access and habituation that make attempts more likely. That's the integrated motivational volitional model in plain language. Its components, the evidence thus far, and what it suggests for prevention. Thank you.